am just kind of a person. I like to think about things as in a pathophysiological way first. And so when we talk about sepsis, we have to break down sepsis is going to be any infectious process that's causing this systemic effect on the body. The main problem with sepsis is not the infection itself, but really the localized inflammation that occurs. So the infection will cause this systemic inflammation throughout the body that causes this vasodilation, causes fluid loss, and causes all those downstream effects that we see. When we move up to severe sepsis, the definition is really when we see sepsis with end organ damage or signs thereof. So ways that we see that would be like an elevated lactate, any EKG changes or troponin bump, somebody with altered mental status, bumped liver enzymes, or acute kidney injury. You can see another myriad of things, but those are kind of the main ones that we're looking for. Septic shock, which is the topic and what we're going to refer to and talk about going forward, is when we see all of those things with hypotension. Hypotension can be later. You can see septic shock with normal blood pressure very early on, but your blood pressure is going to drop when you start to refer to the shock part of it. So in the United States, there's a couple of different things, and I think you used them in Vietnam. You can correct me if I'm wrong, that you guys will use. But for diagnostic criteria, some hospitals are really big on this and really harp down on something called SIRS criteria or QSOFA. They're using a lot. They use it a lot. Most of the papers out there show that these aren't great. They're really just a screening tool because like a SIRS criteria, they're going to rule in a lot of patients that may not actually be septic because these abnormal vital signs can occur with a lot of other disease processes. And what those would refer to would be either somebody that's hypothermic or hyperthermic, having a heart rate over 90, respiratory rate over 20, or a PaCO2 of over 32, or sorry, less than 32, white blood count over 12,000 or under 4,000. You have to have two of those to meet SIRS criteria. Another one that's a little bit newer that is used sometimes is called the QSOFA. And again, you need to meet two of those. And with that, it refers to somebody having altered mental status, a blood pressure with a systolic less than 100, and or tachypnea. The problem with QSOFA is it was really designed in the ICU setting, and it was designed for ICU patients to predict mortality. So it's not one that's easily used in the emergency department. So I don't see it used that often. Really, if people are using anything, it's SIRS criteria. And I think SIRS is better as a tool for like nursing staff or triage staff to make people aware, to raise that red flag that this is possibly a patient that is going to be septic, and just get, things rolling. In general, it's a clinical diagnosis, and most of us, I'm sure you guys are good at recognizing it you just see it so often, and when somebody is concerning or in your concern for sepsis. Just going forward with these patients, so you're going to start with your bedside evaluation. So physical exam, and just key things to think about every time you see somebody you're maybe thinking, hey, this patient could be septic, is obviously looking at their vital signs like we just talked about. Now, some of those abnormal vital signs are caused because of this surge. You get this massive vasodilation, and you can look for those findings from the vasodilation on your physical exam. So an elevated heart rate, you can get a wide pulse pressure, so a high systolic blood pressure and a low diastolic blood pressure. Eventually, that could just result in a decreased blood pressure completely. You can also get decreased capillary refill time. This one, the cap refill, is a really good exam finding to look at in kids because sometimes they really fool you. So cap refill, I like to use in kids especially. Hyperthermia, that makes it a much more specific sign for sepsis, obviously, because there's not as many other processes that cause you to have a fever. Altered mental status is another big red flag that can be a sign, like we talked about, of end organ damage or somebody being further along the line of being sick with sepsis. And then as you're examining them, you're always constantly trying to identify what your sign of or what your cause of infection is. That's really important, because the sooner you can identify the cause of sepsis, the better your treatment's going to be, because you can gear your treatment toward that specific infection. When somebody comes in and you're concerned for septic shock, or you're just doing that initial evaluation, you can always use ultrasound. I am not an ultrasound guru. I'm not great at it. And I remember Dr. Dye last week said that you guys do rush exams. You use a lot of ultrasound. And this is great in the shock patients, especially when you first see them, because you can maybe identify what's something that's causing it. Ultrasound's also a really good tool when you're looking at fluid resuscitation and making sure your patients are adequately resuscitated, or if somebody has other medical problems like a heart failure or a COPD or liver failure, kidney failure, something that may not allow you to give tons and tons of fluid, you can use the ultrasound to see, hey, have I given enough fluid, or my fluid overloading this patient, and really help gear your treatment a little bit better. I put this slide in here, and I can share my slides with you as just a review of the rush exam and where you're looking. And again, a lot of these views, you're looking at the lungs, and it allows you to expose the patient, look at the lungs more specifically, and you might find other things along this, like during this exam, that help you with identifying what's going on in your patient. When you do it, the signs of hypovolemic shock on this rush exam are going to be a hypercontractile heart. So if you're tachycardic, or if you just feel like it's contracting with a lot of force, then that could be a sign. I can't say that I would be able to identify specifically hypercontractility except for tachycardia, but could be a sign. And then as far as the tank, some of those things are kind of what we talked about as far as fluid resuscitation and looking at your IVC, looking at the jugular veins. You can also look for other findings that would be causing hypovolemia to make sure it's not a hemorrhagic shock, or you're not dealing with some sort of blood loss issue as well. Moving forward, so as you start getting your workup on these patients, this is kind of where I like to go with these. If you guys do them, if you do them different, that maybe I always get a CBC. You're looking at, make sure they're not anemic, see what their platelet count is. Sometimes elevated platelet count can really be indicative of an inflammatory process, but if they're anemic or their platelet count is low, it may drive your treatment as well. CMP, are looking for those signs of end organ damage, also any electrolyte abnormalities that may need to be corrected, especially as your patients are hypotensive. If your magnesium is low, if your potassium is low, those can really perpetuate hypotension and make things worse. Especially, you think about sepsis and it's a vasodilation of everything. So you want those smooth muscles to be able to function properly with all the electrolytes. Get blood cultures. That is always going to be that's more kind of for down the line to make sure that they don't have a bacteremia. Lactate, and the lactate is done in the United States. It's significant with our SIRS or our protocols oftentimes with the lactate, because that is one lab value that they've shown, if it's elevated, can be tied to increased mortality. So it's something that's trended as patients get along in their hospital stay. A venous blood gas, or if you guys do ABGs, I tend to just do a venous blood gas in this case, just quick, and you're already drawing blood. So that can give you your pH, base excess, which can help you kind of see if you are fluid down. You can look at the base excess. The pH is important because, again, if somebody's hypotensive, their pH is really if you have a low pH or you're acidotic, then vasopressors or some of those medications that we use for blood pressure aren't going to work as effectively. So really want to make sure you're treating or assessing at least any acidosis. Troponin, BMP, those are to look for any signs of end organ damage or the severity, also to see if anything else is going on. The procalcitonin is something that's done in the hospitals, and kind of one of those tests where the hospitalists like it. It is something that's trended throughout a hospital stay. Is the value important to me in the ER? No, not particularly. But the hospitalists, a lot of times once they're admitted, they do follow these and trend these because it can help them determine how sick the patient is, what further things they may need. Pregnancy test if somebody's childbearing age, just because you always do it. The UA is a urine analysis. And I'm sorry if any of the abbreviations aren't clear, you can always ask me in the chat. I can see it now. But the urinalysis, just to look for signs of infection, same with the chest x-ray. Just listed here, other causes, and just things to think about. You guys can kind of read through them, especially now in this world, is when you're looking for signs, when you're looking for the cause of the sepsis, what's the cause of the infection? Just there's so many things that can cause infection. Kind of talked about a few of these in the slide, but viral studies, if you don't have an obvious bacterial cause, STDs, so thinking about PID or pelvic inflammatory disease in women, especially, that can be a sign that can be missed sometimes or a cause of infection. Meningitis or encephalitis, looking for abdominal issues within the abdomen, that can always be something that you have to think about. Think about epidural abscesses or discitis, other things that can be really easily missed. And then if you have somebody that's severely immunocompromised or an IV drug user, endocarditis, that can be really tricky. But just a thought to the physical exam on any patient that is septic is just so valuable. You can gain a lot of information. Honestly, I always try to get better at it and review those things because there's so many things that we can learn from that. And yes, we have a lot of diagnostic tools in the modern emergency department, but I think it's good to get more of a physical exam and kind of gear your evaluation to that and not just trigger order everything. And kind of the meat of it is the treatment for sepsis. So I think most people know when you have a patient that is in septic shock, the first and foremost thing you do, aside from the workup, is starting aggressive IV fluid administration. Here, when places are protocol driven, there is the 30 milliliters or cc's per kilogram. And a lot of places we're doing this as like a automatically order it. That's what we do here. They've leaned up on it a little bit. And if you look at it, you can kind of give those 30 cc's per kilogram over a 24-hour period or over a slightly extended period if you have reason to. Most people can take this amount of fluid, and some intensivists I've heard say, just give it on anybody. If the worst thing you do, yes, it's not ideal and it's awful, you intubate them, but an intubated patient is better than a dead patient. If you're fluid overloading them and you have to intubate them or diurese them later, it's better than them not surviving because their blood pressure drops or they don't have fluid within their vasculature. That being said, most of the studies show that if you just follow your judgment and you give fluids how you see appropriate, that is sufficient. So most physicians are pretty good at assessing how much fluid their patients need. You're never going to go wrong with a liter of fluid in these patients, a full liter of fluid, unless they're really, really far gone CHF, less than 10% cardiac output, something like that. The other thing some places do, and I'd love to hear from you guys in Vietnam if you do have to do this. I've worked at places where it's an automatic, people are started on broad spectrum antibiotics. Other times you're allowed a little leeway. You can kind of give yourself at least an hour, a little bit of time to try to identify a source. Now with how concerning it is and how much of a problem it may be that we have these super bugs or people that are having these bacterial infections that are just not susceptible to any antibiotics. I think that it's okay to take a minute and step back and try to figure out what you're dealing with. If somebody's really sick, obviously, and you're already starting pressors, by all means, go with the antibiotics. Another thing to consider is a lot of people, their blood pressure will drop when they start antibiotics. And I think that's because they, especially like vancomycin and those stronger ones, it's kind of your body's response to it. But oftentimes I do see people's blood pressure drop even more once those antibiotics start. So just something to kind of be cognizant of. In somebody that's immunosuppressed, or they have a very strange presentation, they've had a weird travel history or really altered mental status, something that is very strange, you can consider antiviral medication or antifungal medication. Those ones, I don't think it's as necessary to start immediately without a really good workup and making sure that you're kind of doing your due diligence to see what may be the cause of this sepsis. As far as vasopressors, the blood pressure medications and anything like that, I typically will not start them till the mean arterial pressure is less than 60. At 65, which you should start to consider them, obviously, and start thinking about them. Almost always the first line in septic shock is norepinephrine. Sometimes in pediatric patients, I've seen people given epinephrine because they can handle it. So a pediatric patient can just tolerate their heart rate being significantly higher, but because you have to remember epinephrine is going to increase the heart rate in addition to causing that. Sure. For me, I always use norepinephrine because most of the patients that I've seen with septic shock, the majority are going to be older patients with comorbidities. Oftentimes you don't know their other medications, what they're on, and norepinephrine is a pretty safe bet. In these patients, if you're using a second line, so say the norepinephrine, you're maxed out on that medication, I will typically go to like a vasopressin. Other people have their preferences, but I think that that's a good option to go along with that. As far as IVs and what you're using for those, I'm not sure what your guys' practice is as far as starting lines, but as far as like starting a central line, for me, if you're working and it's not a big academic center, there's not a ton of people to help you, and you are starting these pressors, it's okay. It's okay if you give it through a peripheral IV for about 4 hours. So that's the time limit. After 4 hours, it is best to use a central line, but for the first 4 hours, you can put it through a peripheral IV. Generally, you're going to want a bigger IV. So at least an 18 gauge, maybe even bigger. And a good site you're not worried about extravasation or it leaking. And you will sometimes get pushback, at least I have from nurses, they'll get concerned, but you can assure them that they're okay, especially while you're just getting things in place to get a central line or doing whatever else needs to be done. After these patients have been on pressors, if they're still hypotensive or if they still look really sick, you can consider steroids. A lot of the studies show no major benefit, which is why it's not routinely used. But I know in these patients that are septic and I have a hard time with their pressure, or I'm getting to my second, third line pressor medication, then I almost always give them steroids, because why not? Who knows if it's going to help. Definitely want to give steroids to anybody that's on chronic steroids. If anybody takes a low dose steroid all the time, then it's really important to make sure they get a boost of steroids, because their immune system, not your immune system, but your body is naturally going to produce extra cortisol in a time of stress. And if they're on steroids, their body can't do that to help with fighting this systemic inflammation. So they need that extra steroid. Like I talked about a little bit earlier, if they're acidotic, so if you get a pH and their pH is low and they're persistently hypotensive, think about ways to correct that acidosis. Sorry, I actually figured out how to use the chat. Yep, I see you guys now. I can see it about the endotoxins. Thank you. I totally agree. But like I talked about earlier, if somebody is profoundly acidotic, their pH is low, a lot of times pressors, they just don't work adequately. They don't work at their optimum capability when you're acidotic. And so you can think about ways to address it. Intubation is a tricky subject with septic shock, because in some way you think, oh, well, it may be beneficial to intubate this patient to take away their work of breathing, to, kind of maybe calm their heart rate down, calm them down, and just sort of decrease other work so that all of their energy or their body's energy can be put into perfusing these vital organs, and you're actually oxygenating everything. On the other hand, oftentimes the actual process of intubation can totally decrease any residual sympathetic tone they have, and they can just go from being tachycardic or hanging on to bradycardic, and then they can have an arrest or cardiac arrest. So you really have to be careful when choosing to intubate a patient. If they are intubated, you can kind of blow off some CO2 to help with that acidosis, to help with the pressors. They're not intubated. You can give a little bit of bicarbonate. Bicarbonate typically doesn't last for a long time. And so it's kind of a short-term solution. But when you're just trying to get somebody not to have a cardiac arrest, or just to get any sort of blood pressure going so they are perfusing those tissues, it can be something done. And you can't even consider doing a bicarb drip. It's just kind of personal preference or what you see fit for the patient in front of you. Some things that they do in the ICU, we're not really doing them in the ER. At least I have not had a patient long enough to do it, but I've seen some great data about really high doses of vitamin C and other kind of supplements just on these patients that do have some small benefit and some decrease in mortality overall. But that really doesn't need to be an immediate thing. And then just going back to fevers, you always want to make sure you're treating their fevers, because sometimes that can improve your tachycardia. You can get the heart rate to slow down a little bit, and that can improve your pump function. So if the blood is able to stay in the heart longer, it can pump out better, it can perfuse those tissues better. So treating these people's fever can be a good way to improve their tachycardia, make them more comfortable, and might help with what you're dealing with. So that kind of wraps up my discussion. And, at this point, before we even dive into questions, I can see the chat now, actually. If anybody has any questions or they want to share anything or add anything, I would please love to hear it or speak up. Well, I will start going through the questions since I'm not getting a lot of takers on my great, but that's okay. Oh, I don't know why. Oh, yes. See, I can see the chat. So first question, 82-year-old female, history of hypertension, presented with generalized weakness, altered mental status for 2 days. Vital signs as follows: heart rate of 110, respiration. Oh, sorry. I am just, there you go. All right. Anyways, respirations of 22, blood pressure that is supposed to be 85/45 for any confusion. And then 94% on room air. Urinalysis shows over 100, white blood cell count, chest X-ray unremarkable, and she's gotten antibiotics. What is the most appropriate next step in her management? Great. Looks like everybody so far has answered A, which is absolutely correct in what we talked about. So in these patients, even this patient, we know what she's gotten her antibiotics. We know her source. We want to make sure she's getting fluid. She's already starting to be hypotensive. And so it's very important that she starts getting those fluids. I almost didn't like the way this question worded. It was from Rosh because she had gotten antibiotics, but they hadn't started fluids. But that was a minor point. Just thought it was a kind of poorly written question, but it works to get the point across. And here's the second question. 67-year-old female presents with septic shock due to pyelonephritis. Temp is 101.2, heart rate of 110, respirations of 20, blood pressure is 94/59, and she's 99% on room air. Apart from antibiotics, what is going to actually help reduce her mortality? And you guys can go ahead and answer in this chat after number 2. So this question, it's hard the way it's written. And again, I got a lot of these questions out of Rosh Review and another book I had for our emergency medicine boards. It's hard how it's written. And I think especially with a language, but when it says apart from IV antibiotic, which following is help, it's going to help reduce her mortality. By reduce, I mean, which one's going to decrease her mortality? So how are we going to help prevent her from dying from sepsis? So going through them, the corticosteroids, like we said, the steroids aren't really going to help with decreasing mortality unless somebody's really, really sick, and the studies aren't great for that. Checking a lactate level is going to help us determine if she's more susceptible to die. So if she may, if she's at risk for dying, the lactate is going to tell us that. So if her lactate's really, really high, then we may say, oh man, this is going to be a sick patient. We better be more aggressive in our treatment because she's more likely to get really sick from this or is already sick from this and may die. But it's not going to help reduce her mortality or decrease her mortality to check that lactate level. What is going to reduce her mortality is to treat an elevated lactate. And the best way to treat an elevated lactate is with IV fluids, because when you have elevated lactate, it means that you're not getting good perfusion. So you're not getting good blood flow through the body and not getting good blood into the tissues. So that's why the IV fluids is going to help, because you're getting the tissue fluid and it's going to stop producing that lactate. So in this case, the answer is going to be it's kind of like the last one, the aggressive IV fluid. When you're concerned about, like in septic shock, if you see the answer of IV fluid, if you guys have to do tests, I know that's not the point of this, but it's usually IV fluids. So this one, just look at the word says to reduce your mortality, and that's with the IV fluids. And that's the best way in sepsis to reduce mortality or to help save somebody's life, is to give them fluids. Next question, and this one's a little wordy, so I apologize, but I'll give you time to read it and kind of read it to you. But the 60-year-old man presents via EMS for altered mental status. Sorry, I'm having a hard time. Let me move this. His wife accompanies him and is the primary historian. She states the patient has not been feeling well for 1 week, started complaining of fever and chills yesterday, and has had an associated headache. The patient was hard to arouse and wake up this morning and was mumbling nonsense. Therefore, paramedics were called. Vital signs reveal a heart rate of 135, respirations of 30, BP of 110/65, temperature of 103.5. On exam, the patient is altered, drowsy, and disoriented. Upon flexing the patient's neck, you notice the patient flexes his knees and hips. What is the correct sequence in the treatment of this patient? Yeah, good. Most of you guys got that. That was good. This one, it's mostly about sepsis. There's a little, when or when not to order a head CT, which is not really what we talked about, but correct, this patient has a fever, heart rate is elevated, and their respirations are elevated. So they look like somebody that is already surged. They're not technically septic shock, but that blood pressure, it has that wide pulse pressure, that pretty big difference between the systolic and the diastolic blood pressure. So they're really somebody who looks like they're probably going to become a septic shock patient or really close to being that way. So you want to make sure they're getting their fluids, they're getting their antibiotics. The sign that they're pointing at is the signs of meningitis, when they're flexing their knees and hips, when you bend their neck. And so when you're concerned for meningitis, obviously you want the lumbar puncture to see so you can get fluid and test it for infection. In this case, they wanted the CT head because of the altered mental status. This person is really hard to arouse and they're talking nonsense. We didn't really go into that, but on this one, you're not sure. You want to make sure that there's no hydrocephalus or increased fluid and that you're risking herniation before you go ahead and do the lumbar puncture. So that's why in this case, there is a CT head included. But as far as the identifying sepsis, you guys nailed it. And question 4, this one talks a little bit about some of our pressors. So 80-year-old woman presents from a nursing facility with fever, confusion. On arrival, she's alert, able to follow commands, oriented only to self. Vital signs are temperature of 39, heart rate of 130, BP 70/40, respiratory rate of 24, and oxygen saturation 98%. Exam is notable for tachycardia, clear lungs, 4-second capillary refill time. She is started on broad spectrum antibiotics, receives 2 liters of lactate ringer solution IV. Repeat vital signs are 38.7, heart rate of 110, BP of 80/50, respirations of 20, saturation of 98% on room air. Physical exam is unchanged. What is the most appropriate next step in this patient's care? And Dr. Wynn, I see your question about the dexamethasone just before we go over this answer. Was that for this? You can write it in the chat. Was that for this question or the last question? If it was for the last, I think you're probably referring to the last question, and you're right. If you're concerned for bacterial meningitis or Neisseria meningitis, then you would give dexamethasone as well. And it was just kind of what the question was. You could give it on that case. You could also, on the dexamethasone, I think you can wait. You're safe to wait till after you get an LP and get the identifying bacteria, but it's just a rush review question. You're right. And you kind of, a lot of these things, you would do a million things at once. And that's why these questions can be hard, because they're misleading. A lot of times you're doing all of this at once. It's not what's next. It's more what's important or how's the step important, and questions can be poor, but they help us just direct this conversation, I think. So they're good for now. In this case, you guys all got it. D, the norepinephrine drip. So got it right, that this patient's blood pressure was low. She's in septic shock, and she did already get her IV fluid. She already got her antibiotics. Her blood pressure improved, but only slightly. She's still hypotensive and is going to need something more than just fluids. So, you would probably still continue fluids and put her on a maintenance drip, but you want to start some pressors, and norepinephrine is the correct choice here. And last question. So 85-year-old female presents from a nursing home with fever and hypotension. FYI, a lot of these questions, revolve around urinary tract infections, and that's what was found in the review. But I feel like the majority of the septic patients and septic shock patients I have seen are 85-year-old females from nursing homes or older women with urinary tract infections. So it's a good it's a good start and a good place, at least for my practice. But according to the paramedic, she began to have lethargy and refused to get out of bed one day ago. No reported history of cough, shortness of breath, diarrhea, headache, or rash. She has a temperature of 102.4, heart rate is 122, respirations are 22, and her blood pressure is 72/44. She's 95% on Romer. The patient's physical exam is non-focal and routine laboratory work is sent. Which of the following is the most appropriate empiric antibiotic therapy at this time? And I hope this question is okay for you guys, and I'd love to start a discussion with this because I think antibiotic choice, I think it's probably going to vary quite a bit throughout the world because the strands of bacteria with different susceptibilities are going to vary depending on where you are. So in Vietnam, you guys might not have as severe of resistance to certain bacteria as us, and you may not be as limited to using vancomycin. So you may see less MRSA than us, or maybe you see more. So it probably changes which antibiotics you use. And I can already see from the questions that, or the answers, that that may be the case. Because like in the United States, on these patients with an infection, we don't know what the cause of the infection is yet. We very commonly go to vancomycin and piperacillin tazobactam, which is Zosyn. And the biggest things that we're covering is, they're broad, they cover a lot. And the big things that they cover is vancomycin covers MRSA, so methicillin resistant Staph aureus, and the piperacillin tazobactam, or the Zosyn will cover Pseudomonas. Those are two of the big things that aren't covered by a lot of the other drugs out there, or a lot of the other antibiotic choices we have. And that is why we're using those. You guys may more commonly see other bacteria, or like I was saying, you might not have the same resistance that we do. For us, that's what our go-to would be. And that's the last question. So I'd love to hear from any of the people, the doctors from Vietnam, as to what you guys may use in these septic patients that's different from this. Dr. Dai, you want to tell us, what do you use if you have a septic patient? Which antibiotics? Okay.
And you see the patient come with the septic shock. Maybe we use the antibiotics, carbapenem first. And find the reasons why maybe it's the pneumonia, we plus the vancomycin, carbapenem and vancomycin. And the patient have the abdominal pain. We use the plus the quinolone, ciprofloxacin, and the urines. Maybe the urine, we plus the levofloxacin. So we use the carbapenem first and plus vancomycin for gram position. Positive.
Yeah, so really similar things to us. Do you guys use, and do you use a lot of the cephalosporins, like cefepime or rocephin, or?
Cephalosporins, when I think about the patient had meningitis.
Mm-hmm.
When meningitis, I use the cephalosporins first.
Great. As far as, and then just kind of like I said, I want to, as far as basically all the medications that we talked about, do you use some similar things? So as far with your vasopressors, like, are you using norepinephrine, or is there anything else that you use or do differently? Mm-hmm. Yeah. Okay. Mm-hmm. With your bundles, is that a reassessment of their labs, or is that a reassessment of the patient? Like, is that including like a repeat lactate level, or just looking at their vital signs and how they've changed, or everything? Wow. Mm-hmm. Wow, that's great. So are you routinely on these patients, like pretty immediately doing central lines and arterial lines on them right away? Mm-hmm. Oh, great. Mm-hmm. Mm-hmm. Yeah. Mm-hmm. Wow. Yeah, that's impressive. If you can do all that in 1 hour, that's a lot. And like you said, it's always a balancing act of what else you have going on in the emergency department, right? I bet.
It's so slow there, Di. There's no patience there.
How many how many doctors do you usually have on at a time? Is there more than one, or just okay? Wow. Yeah. Oh, okay. Oh yeah, for nurses is tough too, because when you're doing arterial lines, central lines, you need at least one nurse in there to help you with all of that. Yeah. Mm-hmm. Yeah, I always have a hard time setting up that arterial line. I think I've had a nurse show me about 10 times and I still mess it up if I try to set it up myself.
Yes, Doctor, we introduce some technique that when we receive a septic patient in our department.
We do the same, doctor. I run the hospitals. So the patient comes with the septic shocks. We do the CBCs, IPP, and especially we follow the blood track monitors, especially in the patient with the cardiac disease. So the blood track monitors help me to decide to use more fluids or increase the intratrough.
Yes,
for the patient.
Yeah.
Great. So are they, you have put them in every patient routinely that comes in with shock in general?
Yes.
The flow monitor. Wow. That's great. It's kind of just takes any of the guessing game out of it, making sure that you're doing the right thing for your patient. And between the flow monitors and ultrasound, really nice to have that directed therapy for the patients. Dr. Fuller, you have anything that your practice different here in the United States? That's where to round it out. I'm calling.
I think that was a great lecture, Claudia. It's amazing. One of the benefits of getting fellows from different institutions is that you guys bring such a varied experience to these discussions. But it's great hearing about your practice. Dr. Claudia practiced in Taos, New Mexico for a long time with a large Native American population there, just so everyone knows a little bit more about her background. And that's far different than my experience at the University of Utah, where we have every resource available to us. Just like Dr. Shirley will bring a different experience with her background, having trained in Virginia. So you all stand to learn a lot from these strong ladies who are now part of the global health tradition at the University of Utah. So I don't really have anything else to add, though, Claudia.
Okay. Yeah, that's fine. Yeah, I can tell you what it's like being by myself seeing these patients. It's really scary, and where I was, it was single coverage. And so I would be trying to do everything all at once. And so I did not often, there was a lot of times when I gave those, a norepinephrine for 1 or 2 hours through a peripheral IV before I had time or a nurse to find to have the time to do it, because I was just by myself seeing the whole emergency department. So I would see the patients, start them on fluids, get labs ordered if I needed to, see other patients or see what else was going on, and then be able to go back in and start the central line. So I can tell you in quite a few patients, I did run the norepinephrine on a peripheral IV and did okay. A lot of times I did just give the fluids based on what I felt and what the patient needed, pretty aggressively with fluids, and have yet to, knock on wood, have an issue with somebody getting really fluid overloaded. Now I'm going to be working at a large academic center, and I'm not upset to have all these resources, because it's a little bit nicer when you have a team and other people helping you and tools, because these patients decompensate quick and it's hard to see them just die in front of you if they do. So I guess that's it for me. If anybody has any other comments or wants to say anything on chat, or Shirley or anybody, but otherwise, did it work for everybody? How, like, the timing for things being sent out? I can send you the questions tomorrow, and then I can send the Zoom link like in 2 days before the meeting, just so everything's fresh in your inboxes. Because if you're like me, and if I get something a week, if I send it tomorrow, in 1 week, it's hard to find. So I'm going to send the Zoom link much closer to the actual lecture. That worked for everybody? Okay.
Come on, Claudia. Thank you.
Yes. Thank you, guys. And
Great
I'll
job.
see you next week. We're talking about cardiogenic shock. Just this FYI.
Thank you, all of you.
Okay. Thank you, guys.
Great job.
Have a great day.
Bye-bye.
Bye.